Preoperative and intraoperative mapping are different ways of interrogating the brain. They both provide anatomical and functional information that you can combine together and potentiate each other, which means before surgery, we can get anatomical and functional information about the distribution and the well-being about eloquent areas that we can then translate to the surgical setting. And it will allow us not only to plan surgical approaches, but also to determine how aggressive we can be in our resections in our oncology when we come close towards eloquent areas. So that functional information is provided mainly by the preoperative metrics that we can gather, which at the cortical level is mainly given by TMS.
So the NTMS is actually very useful because it is a preoperative mapping of eloquent structures such as motor and speech that I will then see intra-op to see whether they correlate or not with the electrical stimulation of the brain. So as a neurophysiologist, it's very important to have all of the information that we can from patients before the surgery. We want to know where the tumor is located in relation to all of these functional areas to be able to have a plan as to where to locate our electrodes intraoperatively, for example, but also as to what the risk is of neurological damage, right? Both for motor and language areas. I think that IOM and TMS are very related. TMS is a neurophysiology technique, the same as IOM is. And we use the paradigms of stimulation that we use intraoperatively, although different, record similar responses. Like, for example, we record an MEP, we record language errors while stimulating the brain. So for us, it's useful in the sense that, as I said, we can assess possible risk areas that we don't want to invade the surgery, and also location of our electrodes to be able to monitor, to map and to monitor afterwards.
Neuro-oncology, and particularly the resections we do near motor eloquent and language eloquent areas, even though they are responsible for a significant increase in the overall survival of our patients, they actually carry with it a risk for functional deficit after those resections. And we believe, and I personally believe, that the patients should be empowered to take the decisions about what is the treatment that they want for themselves. And when preoperative mapping and cortical mapping and anatomical and functional TMS-based mapping provide us an information with regards to the risk of developing those deficits, we believe, and personally I think, that this information should be conveyed to the patient so the patient can have an informed decision near or with the surgical team about the best way forward for the treatment. So summarizing, TMS provides us risk stratification tools that we can deliver to the patient, and we jointly can take a best decision about the treatment that suits the patient and not the pathology.